Good morning, everyone. Welcome. I'm Lizette Mowatt. I'm a VR surgeon from the University Hospital in Kingston, Jamaica, and today I'm pleased to be talking to you about OCT biomarkers in diabetic retinopathy. So I know this is something that we all deal with, and I want to start off and just spend the next 45 minutes with you guys to talk about OCT biomarkers. So we're talking about two big things here, diabetic retinopathy and OCTs. I have no financial disclosures for this talk. So we're going to go through an overview of the OCT imaging, the main OCT biomarkers in diabetic retinopathy, the relevance of them, the prognostic factors, and a little bit of the clinical applications we can do. So diabetes is a very common disease, and diabetic retinopathy, which is one of the leading causes of blindness in the working age group, is increasing with each year. Pathology is usually due to microvascular neurodegenerative disease. And of course, the duration and the control of the diabetes are the key drivers as to the worsening of diabetic retinopathy. It is actually characterized by microaneurysms, the first sign of diabetic retinopathy, hemorrhages, ERMA, and neovascularization. What tends to cause visual loss is diabetic macular edema, which can occur at any stage, and proliferative disease. So I'm actually looking at the OCT biomarkers for diabetic macular edema in this presentation. So OCT technology has been around from the 90s, but it has improved so much over the years with the type of the OCTs from the spectral domain, high definition to swept source, where it can scan 100,000 scans per second and actually get an optical biopsy of the retinal layers. So this can tell us so much more about the layers than what we would used to see just by looking with our fundoscope. So the imaging outputs we can get are variable. What we tend to look at is that cross-sectional B scan that we want to talk about today, but you can get en face slabs, which are good for looking at conditions such as the epiretinal membranes on top of that. You can also get automated thickness and volume maps. And you can look at different layers or segments within the OCT test results. There are common pitfalls with OCTs, and one of the problems we have is that if there's media opacity, if there's a cataract, if there's a vitreous hemorrhage, it's going to limit the quality of it. You may get artifacts in your OCT, and also if the patient has poor fixation, you will not be able to see the details better. But as the scanning time has improved, the chances of these actually causing a problem gets less and less. So technology has certainly improved OCT definition over the years. So the thing with OCTs is that you can sometimes just get a printout of just one page, but that is not enough because when you want to look at the whole retina, you want to look at the macular area, you want to look at the different slices. So it's worthwhile going to that OCT machine and looking at the different slices through it and not just only at the foveal place, which is usually where the printout is. So if you really want to get an idea of what's going on in the macula, go ahead and take time and look at the actual video of the macular OCT. It can tell you a lot more than just one page. So when you have the picture of the fundus here, you can look and see that there is hard exudates there, a few soft exudates also. You have some hemorrhages there, but you can't just by looking at the slit lamp say this person has a lot of retinal thickening. The OCT will actually give you that topographical map of where exactly is thickened, and it will also give you the quantitative amount of thickening that is actually present. And therefore, this is an excellent way of judging pre and post treatments, looking at the central foveal thickness or central retinal thickness before treatment and after treatment. And you can also see where it is actually localized. This is a B scan of the OCT. Of the retina in the foveal area, and that can give you more added information as to what is going on in the retina, and just not only thickening of the retina, but what else is going on in the different layers of the retina. So let's talk about biomarkers, because this presentation is on OCT biomarkers. So biomarkers are an objective measure of a normal biological process. So a biomarker can be blood pressure, okay, a temperature, the glucose for someone who is diabetic. It can be an objective measure, not only a biological process, of a pathogenic process. So we'll use that to look at hypertension for the biomarker of blood pressures, or cholesterol for heart disease. It can also be a pharmacological response to exposure or intervention. So if you do something to a patient, you can look at what it was before and what it is after. So it can be used for monitoring. It can be used in the response to treatment. It can be used as a prognostic use. If it is this, will we have an improvement if we gave X? And it also can tell you about a susceptibility risk. So that's the benefit of having a biomarker. The OCT biomarkers actually tells us about the severity of diabetic macular edema. It can help to predict visual outcomes depending on what we see within the actual retina itself, and it's helpful for monitoring retinal disease. We also use these OCT retinal biomarkers to tailor treatment strategies, and it can be used as a prognostic information. So it's very useful to have biomarkers and to know what they are and how they can be used. So for us to understand this, I'm glad that quite a few of you are already familiar with OCTs, but those who are not, I'm going to just go through a couple things with the OCT so we know where we are. So this inner retina is where the vitreous layer is. Let's just get a marker here. So the vitreous is inner retina here. The outer retina is where the chorea capillaris is. And then you have the RP Brooks membrane complex, your photoreceptor layers, which consist of your myoid zone and your ellipsoid zone, the external limiting membrane, your outer nuclear layer, which is that dark area here. Then you have the white line, which is the outer plexiform layer. You then have another dark area, which is the inner nuclear layer, because you're seeing that there's a pattern where the nuclear layer is dark or hyporeflective. And then you have another whitish line or hyperreflective line, which is the inner plexiform layer, followed by the ganglion cell layer and the retinal nerve fiber layer. So just the key things for the inner retina, the hyperreflective layers, which are dark, are the nuclear layers. The outer nuclear layer, inner nuclear layer, and your ganglion cell layer. So that way you can orientate yourself when you're looking at your OCTs. For the inner retina, the hyperreflective layers, or the white layers, are the inner and the outer plexiform layers. All right, so you can see that pattern. And if you're looking at the outer retina, there are 4 hyperreflective zones that you need to know about for this talk. One, there's external limiting membrane, which is that zonular attachment between the photoreceptors and Muller cells. There's a ellipsoid zone, which is the inner segment, outer segment junction, which has densely packed mitochondria. Then there's the interdigitation zone, which is a junction between the photoreceptors and the RPE microvilli. And then you have the RP Brooks complex. So those are your 4 hyperreflective zones in your outer retina. So just again, so you can recap before we go into the meat of the matter. So diabetic macular edema can also be classified into non-center involving diabetic macular edema, which is retinal thickening that does not involve the central subfield zone. It can also be classified as center involving diabetic macular edema, that is retinal thickening that involves a central subfield zone, or that 1 millimeter area in diameter. And that's the one that we've been using treatments for anti-VEGF in. So what are the common OCT biomarkers we're aware of? We always talk about the total retinal thickness or the average retinal thickness. We look at that before injections, after injections. We look at the central subfoveal thickness, intraretinal fluid, subretinal fluid. So these are factors that we look at for biomarkers, but I'm going to go through a couple more that are important, and I want you to also look at them when you are doing this. So central subfoveal thickness, the main ones. We can look at the cube, the macular cube, the average thickness and the volume to see how it changes before and after treatment. What's important is intraretinal cysts. And the cystic spaces, where are they located? How large are they? These do make a difference in terms of the recovery. Also, you'll notice sometimes just under the fovea, you have a neurosensory detachment, what we call SND, a subfoveal neuroretinal or neurosensory detachment. That also is a biomarker for the disease process. And sometimes you'll see these hyperreflective dots or foci in it. So we'll talk a little bit about HRF, hyperreflective foci. There's disorganization of the retinal inner layers, otherwise called DRIL, which is a very important biomarker that we'll go into a little bit. And then we spoke about that external limiting membrane, which connects your photoreceptors and Muller cells and gives stability. When that is disrupted, it also can be associated with disruption of the ellipsoid zone, which is where the photoreceptors are. The key points to what, when you pick light up, you need those photoreceptors. So the ELM and the EZ disruption can impact on visual acuity. Other things that can affect it also includes vitreomacular traction, VMT. You need to look at the vitreomacular interface. Is there a membrane there? Is it causing traction? Is it pulling? Is it causing increased retinal thickening? So these are important things to look at. And these last two, we don't really delve too much into them. They are possible biomarkers that could come out in the future. Disruption of the retinal outer layers, DRIL, and photoreceptor outer segment length cross. It just depends on the actual resolution of your machine as to if you're going to be able to see these or not. The main ones I want us to focus on today are the intraretinal cysts, subfoveal neuroretinal detachments, hyperreflective foci, DRIL, the ELM, external limiting membrane disruption, and the ellipsoid zone disruption, and the vitreomacular phase. So intraretinal fluid is a mark of disease activity in diabetes. So if you look at the scan and you see no intraretinal fluid, there probably isn't any active leakage. All right. The macular edema occurs two ways. Either it's intracellular, which occurs in the early stages, and it's a cytotoxic damage of the Muller cells and other neuronal cells, or it can be extracellular, and this is usually in a late stage due to the breakdown of the blood-retinal barrier. When you're looking at the macular thickness and volume, the central subfoveal thickness is important, right? So that's your mean thickness in the central 1 millimeter subfield because it correlates with how much edema is there. And it correlates moderately with the visual acuity, but it's not a reliable prognostic biomarker in diabetic macular edema, just looking at the thickness alone. What you have to look at is a cross-sectional area within the retina, and that is actually a better predictor of visual acuity than just looking at the macular thickness. So the different types or phenotypes of macular edema, you can talk about diffuse retinal thickening, where there's just a little bit of sponginess and increase in thickness in the retina, but you're not seeing distinct cystoid spaces. And then you have intraretinal cysts, which are these hyperreflective dark lacunae. They're usually in the inner nuclear layer and the outer plexiform layer. And they're separated by hyperreflective septi. Then you have the subretinal fluid, which we spoke about briefly, where there's accumulation of fluid. It's actually a hyporeflective space, so it's dark, and it's between the neurosensory retina and the RPE layer. The intraretinal cysts usually occur due to coalescence of your extracellular fluid, and this results in the malfunction of the Muller cells that act like pumps to keep the macula dry, and also the blood-retinal barrier disruption. The prognostic significance of intraretinal cystoid spaces depends on, one, their size, their location, and if they're associated hyperreflective foci. The cysts can be small, less than 100 micrometers. They can be large, we put between 101 to 200 micrometers, or they can be giant cysts, which are greater than 200 micrometers. The largest cysts are usually associated with macular ischemia, because if you look at an overlay of an angiogram, you see there are a lot of areas where it's devoid of capillary perfusion with the large cysts, and therefore larger cysts are a poor visual acuity prognostic factor. So when you see these large cysts, as in this image here below, they can affect the optic nerve, the outer nuclear layer. They damage the inner segment, outer segment, and they can result in irreversible loss of visual function. So even though you do your anti-VEGF and you do get an improvement and you get the retina thin, or you get the cyst, actually collapsed, the intraretinal fluid reabsorbed, the actual vision may not improve much because you have atrophy and you have permanent damage because the cyst has structurally changed the internal connections within the retina. So this is something that can give you a prognostic value when you're planning treatment for patients, that these large and giant intraretinal cysts do not necessarily give you a good visual acuity and is a poor prognostic factor because it leads to irreversible photoreceptor damage, and it can also lead to lamellar hole formation. So this is actually a slide that looked at, it's a post hoc treatment independent analysis of the Yosemite and the Rhine study. So it looked at how well controlled was intraretinal fluid and visual acuity, one, grouping patients who had just one injection of anti-VEGF. So they grouped them into three groups. Group one had a less than 20% reduction in intraretinal fluid. Group two had 20 to 50% reduction of intraretinal fluid. And group three had the greater than 50% reduction of intraretinal fluid. When they looked at these groups and the mean best corrected visual acuity improvement at 1 year, they found that group three, the ones that had the greatest reduction in intraretinal fluid, had the greatest improvement in visual acuity. So the removal of the intraretinal fluid does correlate well with improvement of visual acuity. There's also the post-hoc treatment independent analysis of the Yosemite and Rhine study that looked at the intraretinal fluid volume reduction after 3 injections of anti-VEGF. Again, the same grouping, less than 20% reduction was group 1. Group 3 was the group that had greater than 50% reduction of the intraretinal fluid after 3 injections of anti-VEGF. They found that the mean best corrected visual acuity at 2 years was again with the group that had the greatest reduction of intraretinal fluid. So we know reducing intraretinal fluid plays a significant part with visual improvement. Let's talk a little bit about subfoveal neurosensory detachment. And that's the fluid, if you look at the B-scan ultrasound of the retina, in the lower picture, you can see the fluid is located in blue. That's your subfoveal neurosensory detachment, and you see it in about 15 to 30% of eyes with diabetic macular edema. So yes, you see the intraretinal cyst, but you also see subfoveal detachment. It's thought to occur because there's leakage in the subretinal space because it exceeds the amount of reabsorption that is actually occurring. And the local hypoxia causes RP dysfunction, which just causes further collection of the fluid, in addition to the inner blood-retinal barrier breakdown and the exacerbation of lipids and proteins. We spoke briefly about the external limiting membrane status. If you have an intact external limiting membrane, you're going to find that the fluid accumulates anterior to it and you get swelling that is going to be of the outer retina. If the external limiting membrane is disrupted or compromised, you now will have fluid that now flows into the subretinal space. So this, you can either look at the OCT and see if you can actually delineate the external limiting membrane, but usually when you see the fluid in the subfoveal space, it's because the ELM is compromised. So the ELM disruption is going to correlate with the height of the subfoveal neurosensory detachment in eyes with diabetic macular edema. So the more there is of fluid in the subfoveal space, the more likely we have disruption of the external limiting membrane. So this can also give you a clue as to how much damage or severity is going on within the retinal network. So that's the ELM, which is very important. Now let's talk about hyperreflective dots and foci. So these are actually little dots or lesions that are equal or higher reflectivity than the RPE band. So the RPE band is that one of the hyperreflective lines that you see in the outer retina. And you see these little dots, the arrows are actually pointing to the dots called hyperreflective foci. So they're dots and they're foci. The hyperreflective dots are really well circumscribed dots, and they're usually less than or equal to 30 micrometers in the vertical direction. The hyperreflective foci are not well circumscribed, and the foci are usually greater than 30 micrometers in size in the vertical direction. So there are little things that you'll notice in the actual OCT And these are what we call hyperreflective dots and foci. If you have hyperreflective dots that are greater than 30 micrometers with black shadowing, and you can see in this picture, the green arrow shows the actual hyperreflective foci with the back shadowing of the yellow, it's suggestive of hard exudates. The hard exudates are these lipoprotein deposits that break down due to the blood-retinal barrier, and they usually associated with elevated serum levels and elevated triglyceride levels, particularly if they're subfoveal hard exudates. And if you have subfoveal hard exudates, you might find that the intravitreal steroid implants may be more effective than the anti-VEGF agents with it, in addition to controlling the cholesterol level of the patient. So hyperrefractive foci that are less than 30 microns in diameter and a reflexivity similar to the retinal nerve fiber layer with no back shadowing, usually found in the inner and outer retina, may be associated with what's called activated microglial cells, possibly some element of inflammation here. If you have them greater than 30 micrometers in diameter and the reflectivity is similar to the RPE-Brooks membrane complex, and there is a presence of back shadowing, we could be dealing with hard exudates, or we could be dealing with microaneurysms. So this is actually an overlay of an OCT angiogram, which shows the retinal circulation in pink and the choroidal circulation in red. So what we're looking at could be a hard exudate or a microaneurysm. But the angiogram shows that this would be, because of the circulation there, possibly a microaneurysm. So when you have the red-free image, you can also see the hard exudates typically in a circinate pattern because it's from a central leaking vessel. And they tend to be irregular, dense, and hyperreflective signals. When you look at the cross-section of the B scan, they're actually located mainly in the outer plexiform layer. They are accompanied by a posterior hyperreflective shadow. You can see the associated cystic spaces within this, and you want to look at the different layers to see where the cystic spaces involve. So the hyperreflective foci can result from a neurodegenerative process, and it can occur before you get to diabetic retinopathy. It has been seen before diabetic retinopathy actually occurs. There's a high correlation with very fine hyperreflective foci and the subfoveal neurocentric detachment, as you see in this image, and you may have seen this several times before in your patients when you've looked at patients with diabetic retinopathy. And because of that, we are thinking there may be an inflammatory theory with diabetes in addition to other factors. What they find is that if you have increased number of hyperreflective foci, it probably indicates there's more active diabetes, diabetic macular edema. And questionable, we haven't quite confirmed that if more foci mean worse final visual acuity, that's still yet to be confirmed, but there may be a possibility of that. The studies have shown that hyperreflective foci can be reduced if you use anti-VEGF. But in this systematic review that was presented, they found there was a greater reduction in hyperreflective foci numbers if you use a dexamethasone implant versus anti-VEGF. So therefore, that's why we think there may be an inflammatory component to it, because it responds more to the steroids than to the anti-VEGF injections. So let's talk about DRIL, disorganization of the inner layers of the retina. What is it? So if you look at the horizontal extent in an OCT, B-scan OCT, looking at the area between the ganglion cell layer, the inner plexiform layer, the inner nuclear layer, and the outer plexiform layer, it becomes indistinct and unidentifiable that you cannot see the different layers when you have a case of DRIL. Literally disorganization of those layers. What is the visual significance? You don't have the connections from the photoreceptors carrying the information all the way up to the ganglion cell layer and going to the optic nerve into the brain. There is some disruption there because you can no longer identify the layers as they're disorganized. And this has found to be a robust biomarker that correlates strongly with visual acuity. So if you have DRIL, you have disorganization of your inner retinal layers, chances are the visual acuity is not going to be very good. It's also important because it can predict the visual outcome more than the central subfield thickness. So DRIL is much more important as a biomarker than just looking at the thickness of the retina in the central subfield. Why do we get DRIL though? There's a lot going on there. There's ischemia going on there. There's neurodegeneration. There's ganglia destruction. There's disruption of your bipolar cell pathways. There's loss of transmission. So information is not going to the brain, and therefore you will not be seen in that area. So your visual acuity is going to be reduced. And as a study had shown, if you have DRIL involving greater than 50% of the central 1 millimeter zone, is associated with significant poorer visual prognosis. So the mechanical theory is that probably the edema just extends elasticity of the bipolar axons which snap, and then it just causes disorganization of the inner retina. But you definitely have damage there, and that damage disrupts the visual pathway. So you don't see clearly as you do in an OCT where you see the different hyperreflective and hyperreflective layers. You actually realize they're all disorganized. So let's look for that for OCT because it gives us an idea, one, of a prognostic factor of the visual acuity and also how severe the damage is to this retina. So there's poor definition of the boundaries of the inner retina. There's damage to the axons, the bipolar cells, and nuclei of the amacrine cells, and we have reduction in the vision. And you can see clearly you cannot identify the layers of the retina in this area. Now, DRIL is also associated with, so people who have DRIL, where there's that disorganization of the inner retina, may have increase in the retinal thickness at the fovea. And one study actually showed for 100 micrometers of DRIL present, you had a reduction of visual acuity of one line, approximately 5 letters. So you can kind of judge and have an idea of the severity of the visual acuity from the presence of DRIL and the amount of DRIL. And you can see in this picture, not only do you have the DRIL, but you also have an epiretinal membrane. And if you look, you can see that the ELM is not so well defined because we have fluid in that part of the retina just above it. So what's the clinical implications? The studies have shown that DRIL is associated significantly with the severity of diabetic retinopathy. You have a worse baseline vision and your final vision despite anti-VEGF injections. So it may not do well with anti-VEGF injections when you see disorganization of the inner layers. There's an 8 times greater chance that you will not have a good visual recovery. If you do get a little bit of resolution of DRIL, it can result in a little bit of improvement of vision, but when you have disruption of your neuroglandular connections, it's not going to be easy to get them realigned again. And one study actually found that patients who had DRIL on the OCT actually had a higher body mass index and a longer duration of diabetes. So we do know that the longer the duration of diabetes, the more likely you'll have diabetic retinopathy. We also realize the more likely you will have some disorganization, which may be due to ischemia or neurodegeneration or disruption within the pathway. So this is looking at the picture on the left. You can see there's no DRIL present in those layers, but you have cystoid spaces. So after VEGF, the vision has a good chance of improving once the fluid goes back, leaves the retina, and it comes back to normal thickness because there's no DRIL present. So the pathways are still connected. Where you have DRIL present and there's disorganization, yes, you can give anti-VEGF, the edema resolves, you get a little atrophic look to the retina, but there's disorganization and the vision remains poor. So you can tell before you give the anti-VEGF, chances of the vision improving because of the presence of DRIL within the retina. So DRIL is a reliable biomarker to monitor the neuroretinal impairment in diabetic retinopathy. So we know it's a reliable biomarker. It can be associated with center involving macular edema and non-center involving macular edema. It's a worse baseline visual acuity in patients who have DRIL and diabetic macular edema. And even if you have DRIL and resolved diabetic macular edema, the visual acuity is also going to be poor. And if you have increase in severity of diabetic retinopathy, even if it is proliferative diabetic retinopathy, there's a chance that you may also have DRIL associated with that in the macular area. And we do find patients with DRIL will have an increased thickness. They'll also have structural disruption of the outer retina, which is the key parts, the ellipsoid zone, where the photoreceptors are, and the external limiting membrane. And we've also found with the angiograms that it correlates with the macular capillary non-perfusion and the foveal avascular zone size. So that's a level of ischemia is actually worsened. Is correlated with patients who have DRIL. Let's talk about external limiting membrane now. That's found at the base of the photoreceptor cells. It separates the cell bodies in the outer nuclear layer from their outer and inner segments, the photoreceptors. And it's made of these junctional complexes. So it's not a definite membrane, just junctional complexes between your molar cells and your inner segment of your photoreceptors. So the external limiting membrane has a function of structural support, barrier function, coordination of fluid movement within the retina. So it's a really important structure within the retina itself. And you can just see it there on this OCT. The ellipsoid zone, just to clarify where that is, that's a hyperreflective band that's just below the external limiting membrane. It clinically represents photoreceptor integrity because we're looking at the inner segment, outer segment of the photoreceptors. So if that is intact, photoreceptors are intact, great chance we're going to pick up light and we're going to have good visual acuity provided the rest of the connections within the retina are intact. So the ellipsoid zone or EZ zone is an important thing to look at. And there's a little bit of a correlation between the ellipsoid zone and the external limiting membrane. Usually if you have an intact external limiting membrane, you're going to have an intact ellipsoid zone. However, you have disruption of the external limiting membrane, you're probably going to have disruption of your ellipsoid zone. And one study had shown that with each 100 micrometers increase in disruption of the ellipsoid zone and the external limiting membrane, you have a reduction of visual acuity of about 0.4 letters, which may not be a lot, but at least it gives us a little bit of an idea of quantitating the visual severity with external limiting membrane and ellipsoid zone disruption. Now, the anti-VEGF therapy can restore the barrier effect of the external limiting membrane. And if it causes that to be restored, if you follow up with the OCTs, you will find the ellipsoid zone can sometimes be restored also when the ELM is restored after anti-VEGF therapy. Now, your final visual acuity is going to depend on the resolution of your retinal edema and your photoreceptor integrity, and also the organization within the inner retina. So there are a lot of things that you have to look at to determine what the final visual acuity will be like, or to give us a prognostic idea what the visual acuity may be like if we give an anti-VEGF or treatment for macular edema. So the ELM acts as a survival factor. If you have an intact ELM, you can also get some improvement in the ellipsoid zone. However, if you have disruption of both your external limiting membrane and your ellipsoid zone, you probably have severe damage, which could be permanent in a patient who has diabetic macular edema. So we're going to move on to vitreomacular adhesions, and these are different types. They have described either like a J-shaped or V-shaped, or it just depends on how much pull you have as to the effect it's going to have on the retina. And you find vitreomacular adhesions occur in about 7 to 16% of eyes with diabetic macular edema. It's probably more common than we realize. And patients who have epiretinal membranes with vitreomacular traction and diabetic macular edema usually have poorer visual outcomes. Patients who have early vitrectomy usually do better because they don't tend to get the vitreomacular traction, which results in a lot of other complications. What the studies have found is patients who have vitreomacular adhesions were more likely to have had PRP. As we can imagine, that might have caused a little bit of fibrosis, and therefore you get this these traction and adhesions on the surface of the vitreoretinal interface. So be aware of that laser can also be associated with vitreomacular adhesions. Patients who've had a PVD and also patients who have had early vitrectomy also tend to get improved visual outcomes because they don't get vitreomacular adhesions and the other complications where you get it acting as a scaffolding for neovascularization to grow in proliferative diabetic retinopathy. So if you look at a study that looked at patients who had diabetic macular edema, and 55% of the eyes with attached hyaloid, so the hyaloid, the vitreous was still attached, had diabetic macular edema, but only 20% of eyes who had a PVD had diabetic macular edema. So a PVD is protective of diabetic macular edema because you don't have that vitreomacular adhesion or traction, which gives it that pull. Because this vitreomacular adhesion also affects the transvitreal oxygenation, and it causes the proliferation of the vitreous remnants on the ILM, and that's why you get these fibrosis and further traction occurring. So the vitreomacular interface is a very important part to look at when you have diabetic macular edema, because it could be part of the reason why you have diabetic macular edema and may not be that helpful to give an anti-VEGF. There's something called a taut posterior hyaloid face, which is seen in about less than 3% of diabetic macular edema. And this causes macular edema that does not respond well to any treatment. And these patients who have a taut posterior hyaloid face, not just a vitreomacular traction, but definitely a taut posterior hyaloid face, could benefit from pars plana vitrectomy or removal of the posterior hyaloid. So these are just OCTs of different types of vitreomacular traction. For the one to the left, that's sort of a V-shaped one that it may give way, release spontaneously without any treatment. Some people have tried giving anti-VEGF to see if it can physically just detach it. Remember, it can detach and cause a macular hole with these conditions. So these can spontaneously resolve. For the ones that are the one on the right, it's more a flat, broad-based retinal membrane, flat, broad-based traction. And those do not usually, they don't spontaneously resolve as in the V-shaped one to the left. So those usually require vitrectomy and epiretinal membrane peel to deal with the situation. So I'm just going to talk very briefly about DRIL and PROS. Basically, we don't use that now because the resolution is not something that we have in all our OCTs, where we can look at disruption of the retinal outer layers, which is a damage or disruption of the photoreceptors and their outer segments, because they indicate the severity of damage. As you can imagine, photoreceptors, if damaged, will impact on vision. And then some studies have looked at the distance between the inner segment, outer segment junction, and the RP, what's called the photoreceptor outer segment length, to see if this can be associated with some prognostic factors. And they found that if you had a very short photoreceptor outer segment length, it was significantly associated with diabetic retinopathy or diabetic macular edema, or people who have worse visual acuity in patients with diabetes and macular edema. So I'm going to just end with the biomarkers that are really of significance. Your central subfoveal field or your central macular thickness, which will indicate diabetic macular edema severity, and it can give you an idea of the treatment response. The intraretinal cyst, which tells you the sign of active edema, because intraretinal fluid suggests that there is active edema. The larger the cyst, the more chronic the cyst, the less likely the vision will improve because connections and structural change would have occurred in the retina. Subretinal fluid can occur when you have external limiting membrane disruption. It can be associated with inflammation and worse visual outcomes. Hyperreflective foci, they can reflect either hard exudates, or it can be microglial activation or early neurodegeneration. They do respond to intravitreal implants more so than they respond to anti-VEGF. So it's thought to have an inflammatory component. DRIL, or disorganization of the retinal inner layers, is a strong predictor of poor visual outcomes with the treatment. And the ellipsoid zone disruption correlates with photoreceptor damage and worst vision. So that's just the key OCT biomarkers that I want you to use when you're looking at your OCTs, assessing your patients, planning therapeutic interventions, trying to give prognostic advice to patients. So we're going to go through the post-test questions. The first one, how confident are you with reading OCT? Okay, good. And let's go on to the next question. From the Yosemite Rhine analysis, which OCT condition when reduced is best correlated to visual improvement? Very good. Intraretinal fluid. Well done. So we're going to go on to our third question. Hyperreflective foci. Good, good. So we think it may have an inflammatory component to it. It can sometimes be present before you get the extensive diabetic retinopathy. It does respond to the intravitreal steroids more so than anti-VEGF. And now disorganization of the inner retinal layers. So for DRIL, great. So the studies have shown that it involves greater than 50% or more than 500 micrometers of the central area, that's a horizontal extent. It's associated with the worst visual acuity prognosis, and that's one of our more robust OCT biomarkers for visual acuity. So thank you for your time, and I hope that you have enjoyed the presentation, that it's helped a little bit with things. There's another question, do any HRF require angiograms? No, you don't necessarily have to do an angiogram for it, but if you do have the angiogram overlay, you can see if it's a microaneurysm or if we're dealing with a hard exudate. And the differential for the hyperreflective foci can be hard exudates, or it can be microaneurysms. It can be, if they're very small, it can be due to the microglial changes or degeneration within it or inflammation. There's an interesting question here. Where you've asked, would you go straight to steroids as opposed to anti-VEGFs when you have biomarkers indicating inflammation or poor visual outcomes? So for me, I always tend to start with the anti-VEGFs for diabetic macular edema. And if I'm not getting as much response I'd like, or I do feel that there's that chronic or inflammatory component, I will add the steroid to it. I don't do implants. But I do find that when you do the steroid, you do find a little bit more improvement with it. Someone asked if the steroid injection and anti-VEGF can be given together. I never give them together. We always do one injection and then just see the response, and then you can do another one several weeks later. Right. So how do reflective foci influence treatment decisions and prognosis in diabetic macular edema? So we're still not certain. I mean, there's still tests that are trials that need to be done to see, but what it has shown is that it does respond to both anti-VEGF and also steroids, more so to steroids and anti-VEGF. It is reduced in number, but in terms of a definitive correlation with hyperreflective foci being reduced versus visual acuity, we don't have that as information. So right now, it's just an interesting fact, the hyperreflective foci have been reduced. Okay, so Dr. Al-Safri is asking, what's the clinical relevance of external limiting membrane and ellipsoid zone disruption on OCT in diabetic retinopathy? So that the external limiting membrane is really important in terms of keeping the health of the outer retina healthy. So you find when it's disrupted, you can get subfoveal near-central detachments. Once you find the ellipsoid zone, which is a photoreceptor segment, disrupted, you will then find the visual acuity is significantly impaired. And if there's significant disruption, probably there's a chance that the vision may not improve post-treatment. So someone has asked, would you recommend PRP or focal laser in diabetic macular, I assume they put DM red, so I assume they're meaning diabetic macular edema. So for central involving macular edema, so macular edema involving the central subfield of 1 millimeter, we usually treat with anti-VEGF. We don't tend to use laser in those areas. Micropulse laser has been used in the past, both for non-center involving and center involving, but we typically use anti-VEGF treatment for center involving. Someone had asked if there are OCT angiogram markers for diabetic retinopathy. There are quite a few that can be qualitative and quantitative, because you can look at the level of non-perfusion. You can look at the actual flow. You can look at the actual vessel density. That gives you an idea of how much perfusion and ischemia is there. So there are some for that, and that's constantly evolving as OCT angiograms evolve. All right, there's a good question. How do you identify ischemic maculopathy? And that's one of the things I always tend to do an angiogram for my patients, OCT angiogram when I do the OCT, because yes, you can look at the macular thickness, you can look at the changes of DRIL, etc., and you can look at it pre and post. But if you do the OCT angiogram and you see that there's loss of the normal contour of the foveally vascular zone, or it's enlarged, or there are large areas of capillary dropout, you know that patient is ischemic. So even though you do the anti-VEGF, even though you get the reduction of the cysts and the intraretinal fluid out, if there's a high level of ischemia, it probably will not have an improvement of visual acuity. And if you do this repeatedly, several months of this and you're not getting any significant improvement of visual acuity, and you look at the angiogram and you realize the patient's ischemic, then it doesn't make sense to continue. Because if you have an ischemic macula, no matter how much you try to dry it out, you're not going to get much visual improvement. So it's very important for me, and when you're looking at patients, that the circulation is assessed, because thickness, retinal connections, important, but if the circulation and blood flow to that area is not good, you're not going to get a good result. Okay, so that's a key thing. OCT angiograms is probably the next thing that I'd like to talk about next, because you can use them in combination with OCTs to determine the next step. The question, when we have a subfoveal edema with signs of activity, we do injections. Okay. I think that we had answered that if it's subfoveal, yes, we would tend to do anti-VEGF injections for that. Okay. Someone is asking Dr. Sani to differentiate between non-proliferative and proliferative diabetic retinopathy. So basically, two big groups, non-proliferative and proliferative. So non-proliferative will have those usual changes of your microaneurysms, your hemorrhages, dot and blot, which get worse when the severity increases. You'll have the vascular changes, the hard exudates, retinal thickening. Once you get neovascularization, once you get new vessels growing, whether it is at the disc or elsewhere, you're now at proliferative diabetic retinopathy. Okay. This is an interesting question from Dr. Listel. In diabetic macular edema with intact posterior hyaloid, in the presentation, you said that the anti-VEGF treatment doesn't help very much with the edema. What would be the correct approach? Okay, what I'm going to say is that you'll find if you have diabetic macular edema and you have an epiretinal membrane, you'll probably get some improvement every time you give the anti-VEGF. You get some improvement and the central subfoveal thickness reduces. But if the epiretinal membrane is giving you adhesion with traction, you're going to find that the thickness is going to keep increasing after you've done the anti-VEGF. So you get a response, but it's not persistent. And when you find you're not getting the actual response you want from the anti-VEGF, then I think it's time that you think about doing an ER and peel. And particularly if the hyaloid, if there's a taut posterior hyaloid face, you really want to peel off the epiretinal membrane. I don't tend to do an ILM peel every time I do an ERM peel, but some doctors may do an ILM peel because they feel it then gets off all the membrane by doing an ILM peel. Okay, so there's a very interesting question here from Philip Labus. Do you use any AI tools for quantifying OCT-A images? So that's fantastic, because I think that is where things are going, where AI can actually read and scan the images and then give us, time will tell, but I think that's where things are going now, because there's so many images that you can put together that you can do an algorithm, and you can probably teach AI software to grade and determine what's happening. So that's something I'm looking forward to finding out about in the years to come. And it may not be years because things are going by so fast now in terms of AI. There's a question, is there any genetic contribution to this retinal thickening? I'm not, I don't I'm not aware of a genetic contribution. I think it's more the control of the diabetes, duration of the diabetes, and also the other factors. Be aware that if they have, we spoke about DRIL being more present in people with a higher body mass index. So if you are a little bit more overweight, also patients who have a longer duration of diabetes, they're more likely to have it. All right, so this is interesting. This Dr. Shivora wants to know if you gave anti-VEGF for diabetic macular edema with no response, and then you tried intravit steroids and got some response, can you still go back to anti-VEGF and get some response? I think we'd probably have to look at that OCT very carefully and see what the response is, because if the response is with intravitreal steroids, is it definitely diabetic macular edema we're dealing with alone? Or is there a uveitic component to it? So it's good to look at that case really well. And sometimes you can do the combination therapy, but not on the same sitting. Because as I said, sometimes I'll do the anti-VEGF, and then if I just need a little bit more lowering, I may consider doing the steroids for that. There are quite a few questions here. Okay, so that's an interesting question here, Dr. Hafiz. Can we differentiate proliferative diabetic retinopathy from non-proliferative diabetic retinopathy on the basis of OCT only? And that's interesting, because for you to have proliferative diabetic retinopathy, you're going to have neovascularization. And if you're looking carefully at your OCT, sometimes on the surface of the retina, you may be able to see neovascularization, but it's not an easy thing to do. All right. So I would say the best way is actually just to look with the fundus, look carefully for neovascularization, and in the central area, also towards the mid equator along the arcades, because what they've found is that you can have correlation when there's some ischemia in the central area. You can also have it in the periphery. They found this in sickle cell disease. So if you have macular ischemia, you may also have it in the peripheral part of the retina. But in terms of trying to decide if you have proliferative diabetic retinopathy, I think the gold standard is just have a good look in and just look around the whole fundus, looking at the disc, following each artery, each arcade out to the periphery, looking for any neovascularization. Sometimes you may see ERMA, sometimes you may see collaterals if they've had a branch retinal vein occlusion before. But you can recognize the new vessels because they're usually free-ended, they don't connect to anywhere. And if you do a fluorescein angiogram, then you can see them actually leaking. I like this question. What are the criteria for treating diabetic maculopathy? Diabetic macular edema. Is it visual acuity? Is it macular thickness? So I think you have to look at everything together with the OCTs and the parameters, because sometimes you may have a patient who just has just a very mild retinal thickening, vision's 20/25, a little out of control. And I find that if they just control their sugars, they actually just sort of settle down without having to give any injections at all. So you don't necessarily have to treat that. If you look and you see inside there are large cysts, or a fair amount of cystic macular edema, then I think that patient will need, particularly if the vision is worse in 20/25, will need. Um, can some cases of edema resolve with PRP and good control of blood glucose and blood pressure? For mild edema, I do think if you can control blood glucose, good blood pressure, exercise, healthy lifestyle, it can settle. The edema does not usually settle with PRP. Sometimes PRP may make the macular edema worse. So if you're planning to do PRP, it would be best, and they have macular edema, it would be best to treat the macular edema, okay, and then do the PRP, okay? There's some great questions here. There's some great questions here. It's moving quite fast. Does OCT tell how much micrometers thickness the retina has? Absolutely. And it has the on files where it can do a topographical map. So you have the actual fundus. You can actually map out where the macula is, where the fovea is, what's the thickness there, and what's the thickness around it. So you can see where it's thicker, whether it's closer to the disc or further temporally that we have the leakage. And that's how we use to monitor. That's one of the biomarkers we use to monitor. Can OCTA differentiate new vessels from collateral? So that's a good question, Dr. Shu, because typically OCTA is just looking at, it's not like the fluorescein angiogram, which is dynamic and can see flow that is actually leaking. So the FFA is actually more gold standard to see leakage from neovascularization than OCTA. So yes, if you're going to do new vessels, you might find this easier with an FFA than the OCTA. But just looking at the actual character of the vessels can give you an idea when you visualize them if you're dealing with new vessels or collaterals, because collaterals will go from artery to vein or they will loop over and they just carry blood flow and connect blood flow. New vessels just have a free ending, they're not going anywhere. They actually are almost like a network spanning out. There's a question, how do we protect our retina from any attack of microbes? So this will boil down to giving intravitreal injections because intravitreal injections are introducing something into the eye and that would get access to the retina. So the access to the retina either by intravitreal injections or something that goes through the bloodstream. So something like toxo. So that's a big answer to that, for that. But definitely when doing intravits, always make sure you use your betadine. And some people do or don't do prophylactic antibiotics. I do prophylactic antibiotics for 5 days. However, it's someone who's getting like over several years of getting anti-VEGF as in a age-related macular edema. I don't do prophylactic antibiotics because we don't want to cause antibiotic resistance. But you just have to gauge a patient, their social situation and would they benefit from prophylactic antibiotics. There's an interesting question here, Dr. Leseno. Will pregnancy-aggravated diabetic macular edema influence treatment at any trimester, or it doesn't really matter? That's a very good question because you want to be careful doing a treatment with patients who are pregnant. Even though we're doing things intravitreally, we're not certain of what extent it is actually going to affect the baby. And to be honest, I've never given anti-VEGFs in a pregnant female. I've usually ended up having to do PRP because usually they have more so neovascularization coming to their third trimester if they're going to have severity of their diabetic retinopathy. But that's an interesting point. Okay, so someone has asked, does stem cell therapy work for it? I am not in a position to give you an answer for that, but let's see what happens in the future. I mean, there are treatments that it can do. I'm not aware of anything for diabetic macular edema. I think a person's jumped. Okay, Dr. Mohammed has asked, would you please repeat the point about central thickness as a biomarker? So one of the first things we used to do before we got these really high definition OCTs was just look at the central foveal thickness. Usually it's about 180 micrometers. With edema, it can go to 300, 400, 500 micrometers. So if it's about 400 micrometers pre-treatment, we do the treatment and it comes down to 200 micrometers, that's a good sign. So yes, the central foveal, subfoveal thickness is important, but what I want you to look at is not just the thickness, but look inside the OCT. Look at the different layers. Can you tell the hyperreflective layer for the inner retina? Can you see the organization of that? Because if you can, then you don't have DRIL. If it is disorganized and you've lost where the hyperreflective areas are, then you have DRIL and that will impact on the visual acuity. looking at your cysts. Small cysts usually absorb quite nicely because they're due to intraretinal fluid. Larger cysts can really push the neurons and the vertical connections between your bipolar cells all the way up. They can push and disrupt those. So even when the cysts get smaller, the intraretinal fluid clears, disruption is still there. And you get DRIL, and therefore you don't get good visual acuity. So don't just look only at the retinal thickness, look within the OCT itself. But you're going to need to kind of not just look at that page printout. You really sometimes have to go to the OCT and just look through it and see what is going on. All right. Possible treatment for PVD. So we don't need to treat a PVD. It's a good thing if they have a PVD because you're not going to have that scaffolding for the neovascularization to grow into. So a PVD is good. All right. Just as I said, if you have a young diabetic that keeps getting recurrent vitreous hemorrhages, particularly insulin-dependent, early vitrectomy is good. It gets rid of that scaffolding that would cause the neovascularization to grow upwards vertically because the vertical ones do not respond as well as a flat neovascularization to PRP. And when it grows vertically upwards into the scaffolding of the vitreous, that's when it can rupture, tear, and cause a vitreous hemorrhage. So early vitrectomies is always ideal for these patients. But I really hope that you guys have enjoyed this presentation. I hope it sort of opened up your mind to reading the OCT a little bit more carefully and also giving some prognosis to patients. It doesn't make sense if you have these large intraretinal cysts that you repeatedly give anti-VEGF, nothing is happening because they're actually structural changes that are there. That even if there's fluid that's leaving, there are structural changes that have been there for chronic cysts that have been there for months or years. So you have to look and see if doing the anti-VEGF is actually benefiting your patients because you don't want to be repeatedly given anti-VEGF and there's no improvement. So you need to know when to stop. And looking at the OCT biomarkers gives you an idea if you've got benefit with the anti-VEGF. If you have DRIL in a patient, would you use a combination of both anti-VEGF and steroids? I'd actually just use anti-VEGF and just see how they respond to it. So there's a question from Dr. Rubio. Would it be advisable to have a macular OCT since the very beginning of diabetic diagnosis as a reference point or early changes detection? So it really depends on your setting. You know, some settings may do OCTs on diabetic patients every time they come. The setting I'm in is not a high resource setting, so usually I'll do when I suspect that there is a change, patient is not 20/20 vision, I'm seeing something I'm not happy with, that's when I will do the OCT, OCTA. But I don't do it on every patient every time, particularly if they're well controlled. About OCTA. OCTA is something that I use alongside OCT because the angiogram is really important in terms of the circulation if there's ischemia. What would be the best OCT resolution to see biomarkers? And would the spectral domain OCT be sufficient? So the spectral domain is more of the mid-range. It can see certain things, but if you have the high definition or swept source, that can give you a lot more information. And swept source is also giving us information about the choriocapillaris, because you know that there is some association with the actual perfusion of the choriocapillaris with the outer retina. All right, so who knows, in time to come, we might be looking at the thickness of the choriocapillaris with diabetic macular edema. How many doses of anti-VEGF do you give before you try intravit dexamethasone? So normally I'll do three injections and then decide, depending on how it looks, you may decide after one. It just depends on the clinical case that you have in front of you, how it looks and how long the history is, and if there's any other signs associated with possible inflammation in the eye. So that there's no definite guidelines with that. It's kind of on a case-by-case basis. All right, so this is a good question. Dr. Bibi has said, can you have severe diabetic retinopathy with 20/20 vision? There is a good case that you could have severe diabetic retinopathy with fairly good vision if you have extensive neovascularization. So don't just depend, okay, they're not hand motions, they're not cone fingers, they're 20/20. They probably don't need to have a dilated eye examination today. You may be surprised. You dilate them and you see these abnormal blood vessels in the periphery. You may not necessarily have, extensive macular edema or subfoveal macular edema, but the visual acuity does not necessarily correspond to severe diabetic retinopathy because you could have proliferative changes, extensive neovascularization, and still have fairly good vision. And that sometimes, I must say, with patients, can be a deterrent to you doing laser treatment because they'll come to you, you look and you see the extensive neovascularization, their 20/20 vision. You explain to them they need laser treatment to get rid of the blood vessels because if they don't, they're going to end up getting floaters. Bleeding will occur and they will lose their vision. And most of them think because I have 20/20 vision, I have good vision, I don't need laser. And that's one of the issues where patients may not want to have laser because their vision is good. One thing you have to bear in mind is that even though you do laser, it takes 6 weeks to work to allow the regression of the blood vessels. So even though you do the laser, they can still bleed in the first 1 to 2 weeks if they have hypertension and other situations, they can still rupture and bleed after laser. Okay. And this sometimes makes patients think the laser made their vision worse. So you have to really let patients know when they're 20/20 vision and they do have severe diabetic retinopathy, usually proliferative disease, the reason why. Okay? Because this is something that if you don't treat, there's a good chance that you will lose vision from bleeding if you don't treat proliferative disease. So there's still a gold standard and a place for laser. Let me just say that for patients. I realize some people will do Avastin anti-VEGF for proliferative disease. It's important to realize proliferative disease is because of poor perfusion, and anti-VEGF really will just allow the regression of the neovascularization, but the ischemia and poor perfusion is there. So you still need to do laser treatment to ablate the peripheral retina to prevent the VEGF drive. Otherwise, the neovascularization will come back and you'll have to keep repeating the anti-VEGF. So if you have a low resource area and you don't, it will be easier to do PRP and treat the proliferative disease rather than to keep giving an anti-VEGF. If there's macular edema with proliferative disease, yes, the anti-VEGF can help the macular edema and it can also help the proliferative disease. Remember the poor perfusion ischemia is still there. So I tend to also do PRP in the periphery if I do have proliferative disease in addition to macular edema. How do you differentiate, microaneurysms from hemorrhages? So that's interesting. So your microaneurysms are the first sign of diabetic retinopathy, and it's really just you've got your loss of your pericytes in the vessel wall, and you now start to get an outpouching of the blood vessels. And they're literally dots, okay? Sorry, they're literally just circular areas, and they're very tiny and associated with the vessels. The hemorrhages, more so, they can be dots, but they're usually larger than microaneurysms, okay? And they're more dot and blot-like. So it's almost like the size that you see the microaneurysms, but it's not that easy to use unless you're using a high magnification. All right. I think we've done really well. We've gone through a lot of questions. I hope I've answered your questions. I hope that I've pointed out the key biomarkers for you to bear in mind. And I'm glad I've just had a really interesting audience. You've got some really great questions here. And I think with AI, there's a lot that is going to change over the next few years, particularly with OCT angiograms, in terms of us determining severity, prognosis, and possibly treatment. So with that, I'm going to end this webinar. It has been an absolute pleasure to talk with you, and I hope that you have enjoyed this talk. Thank you.